Respected chairpersons, learning audience, and the dignitaries. First of all, I'd like to thank the IPDI Foundation for having me in this afternoon talk. My topics will be minimum as new aortic replacement with concomitant aortic valve replacement. It is a case report. And I am Dr. Shweta Gupta from Square Hospitals Limited. I have no disclosure to make. Aortic valve disease, mainly aortic stenosis, is associated with ascending aortic aneurysm. Both aortic stenosis and ascending aortic aneurysm are now frequently treated simultaneously, depending on whether the lesion may be repaired or requires replacement. In modern era, reducing surgical trauma to achieve faster recovery is the goal for every cardiac surgeon. So the journey with minimum aortic valve replacement is more preferred than the standard procedure. Minimally invasive procedure provides better thoracic stability and improves cosmetic purposes. We hereby report a case who was successfully went through surgical aortic valve replacement with ascending aortic replacement through a minimally invasive approach. This was our first reported case of its kind by our team. So our case, 33-year-old young male patient, severe aortic stenosis or moderate aortic regurgitation, bicuspid aortic valve with dilated ascending aorta. He was having exertional dyspnea with palpitation for 3 years and systolic over the aortic area. He had no biochemical abnormality. Imaging shows his echocardiogram was showing bicuspid aortic valve with severe aortic stenosis with moderate aortic regurgitation. And he was having a dilated ascending aorta. Ascending aorta was 4 6 mm. Normal biventricular functions. CT aortogram also supported this facts, and he was having dilated ascending aorta in the CT aortogram. The valve was calcified and normal aortic road with descending aorta and coronaries. So what should we do? The guideline is saying in patient with bicuspid aortic valve who are undergoing surgical aortic valve replacement, who have a dilated aortic root or ascending aorta 1 to 45 centimeter, 4.5 centimeter, concomitant replacement of the aortic root, ascending aorta, or both is reasonable when performed by a multidisciplinary aortic team. So what are the options? We had surgical, we can do for surgical aortic valve replacement with ascending aorta replacement by upper knee, right entorthotomy, or median sternotomy. We chose the upper knee because the selection criteria, according to the selection criteria, the aorta was 50% on the left side. On January 2023, after optimization of the patient's condition, he was operated through upper mini sternotomy. Incision was from second to fourth space and J sternotomy. We used these types of single-bladed sternum spreaders to apart the sternum. Incision was about 9 to 10 centimeter. Thymus was dissected, pericarditis was done, and pericardial stay were taken. These stay sutures are very important. 6 stay sutures are placed by blowing the aorta upwards and facilitates the dissection for replacing the aorta. Aortic root was normal and ascending aorta was found grossly dilated. Aortic tipping was done around the aorta and aorta dissected free from the, it was made free from the surrounding fat, pulmonary artery, and the ventricular valve after the STJ. We cannulated the aorta centrally and 2-stage venous cannulation, root CP, and it was vented through right upper pulmonary vein. We applied the cross-claim, the amniotic was given, aortotomy was done, 3 to 4 millimeter from away from the cross-clamp, and aortic valve was checked for severely calcified stenosed. Proximal aorta was resected after the STJ, and aortic valve was replaced in usual manners with interrupted valve stitches, 10 to 1 millimeter Onyx mechanical aortic valve. Sizing of the tube graft was done with the valve sizer, regular valve sizers. Proximal aorta was sutured with 24 millimeter Dacron tube graft with double layer polypropylene, first 40, then 50. The later heart was delivered with low flow carbon dioxide insufflation throughout the procedure, and after completion of the proximal aortic anastomosis, we filled the heart with blood by stopping the vent and using folicatheter for outflow from the cardioplegia line. This ensures delaying as well as the detection of the proximal suture line bleeding, if any. BioGlue was then applied. We use usually TCM Bio. Someone can use this BioGlue from another company. During the unwinding, distal anastomosis was completed, same fashion, two double layer of suture, 40 and 50. As T ensures proper blooding, we release the cross clamp, but before releasing cross clamp, pressing were placed at the RVOT. Heart was then gradually weaned from CPB to normal sinus rhythm. We usually start hemostasis on partial bypass and put the chest tube as well. T was again done to show any residual air in the cardiac chambers. Then we decolonized and administered protamine. Total CPB time was 150 minutes and cross clamp time was 84 minutes. Hemostasis completed and chest closure was done with normal sterile wears. We have done a few aortic cases from October 2020 to March 2023, and replacement of the aortic valve during aortic surgery is typically time consuming, but minimizing surgical trauma for quicker recovery is a key goal in cardiovascular and thoracic surgery. Studies showed that MI aortic surgery is comparable to open sternotomy in terms of hospital morbidity, mortality, as well as midterm survival. Besides, minimal invasive aortic surgery leads to much shorter ICU stay and hospital stays. And stroke rate is also reduced in minimal invasive procedure because before the release of the aortic cross clamp during the weaning from the cardiopulmonary bypass, presence of air in the left ventricle can be precisely detected by intraoperative TE. Furthermore, filling the thoracic cavity with carbon dioxide lessens the risk of air embolism and its consequences by increasing gas solubility. The key to success for our perspective was choose case carefully initially. Aorta should be more than 50% on the left side, thin female, prepare going for femoral cannulation if you need just in case. Be careful of ulnar injury, both during opening and closing. Pericardial stay suture to retract aorta nearer. If you need any reinforce, please reinforce it on the first time. Cover the aorta with pericardium. Open the right lobe to prevent unwanted tamponade. Don't hesitate to convert to MS. We have done a few aortic replacement along with the aortic valve replacement through upper partial sternotomy. The short-term results are promising and very much satisfying from both patient and surgeon's perspective. Regardless of the degree of repair from supracoronary ascending replacement to substituted root surgery, minimally invasive aortic surgery conducted through partial upper sternotomy is a possible alternative to full median sternotomy and safe in appropriate patients. Thank you.
Yeah, thank you, Dr. Shulkut Gupta, for your excellent presentation. Now the floor is open for question and answering. Any question? We have 4 minutes in hand for question and answering. Please introduce yourself. Yeah, it's okay now.
This is Dr. Faizul Islam, as you know. Audible? Okay,
Yeah,
it is said that the aorta lies just behind the manubrium sternum. So, aortic surgery, the first minimally invasive surgery that we started through the mini sternotomy is the aorta. But if you need the valve sparing, the reconstruction of the deep root, then do you face any difficulty with this approach?
We never have done any valve sparing aortic root replacement through this approach. It is a supracoronary ascending aortic replacement.
Okay. And next thing is that do you practice, the Ozaki?
Ozaki, I have no experience on Ozaki.
Okay, thank you.
Thank you very much.
Dr. Shulkut, I have
Any
a question
question?
for you. I'm Dr. Arman Wazud, consultant, Ibrahim Cardiac Hospital. So you have actually replaced the ascending aorta, which is only 4.5 cm, which is actually a borderline case. What are the other options? Because this is a case, I know your team is a very good team, and I think it's the most expert team for aortic surgery. but a lot of junior may try, because this is a case you should not try it at home. Everybody should not try. What are the easier option for this? Is there any
No,
other
the
easier
guideline
option
is,
for?
I got your question. The guideline is clearly saying that if the ascending aorta is more than 4.5, you have to replace it if the team is very much experienced, and if it is done in a center which is doing routinely this aortic surgery. It is a class 2A indication.
Normally, what happens when there is
Normally in a bicuspid aortic valve, 5.5 is the cutoff value.
normally what happens in case of tight aortic stenosis, there is post-stenotic dilatation of the ascending aorta. This is very common. And the dilatation has a peculiar tendency along the convexity of the aorta, in the ascending aorta. You can easily placate the along the convexity. That is the easier option. I think anybody can do it. This is easily reproducible. Why did you need to try this?
But this is a bicuspid aortic valve.
Still.
You have to do it. If you cannot perform it, that's a different issue. But its guideline is saying if it is an experienced team, you should perform it. Thank you.
Any
question?
Any comment from the Dr.
Actually, the problem here it is clear, aortic stenosis severe. So indication was there for aortic intervention, not the ascending aorta. Think separately. Indication was aortic valve replacement, so you are going to operate for that reason. But here, the patient is having ascending aortic dilatation, which is more than 4.5. What to do? You have to go for aortic valve
The
replacement.
thing is that
This is-
then
yeah.
they are going for mini AVR, but on ground they say they are thinking it should be more beneficial for the patient if the route is changed. Then they did it through the mini. That's
Here-
the case report.
Here, some of our patients, actually Farooq sir and our team, when operated for these borderline cases and left it alone, we had some aortic dissection in 3 to 4 years follow-up, at least 4 to 5 cases we had. So only we replaced aortic valve having 4.5 to 5 centimeter ascending aorta, leave it alone. Then in follow-up we had 4 dissection at least we had. In our follow-up, there may be more dissection which are not in our regular touch. Thank you.